Welcome to this BJSM Google Hangout, and I've got the pleasure of being with Paul Hodges, who will be very well known to many of you. He's a professor at the University of Queensland. He's a leader in a Centre for Research Excellence, and he's visiting Doha, Qatar for the Qatar International Pain Conference. Paul, thanks for joining the Google Hangout.
Welcome. Nice to be here.
And we're going to talk about just three simple misconceptions that you and I know that people have. And let's begin with the first one, where people think that core stability is one thing and then other people think it's another. So it is a confusing concept to some, and I've had trouble with that myself. So if someone says to you, Paul, what's core stability? What's stability? Why is it important? What do you say?
It's a really important point, and there is huge misconception. And one of the things I think is fundamental is, to me, the idea of core stability is all about optimal control. And one of the problems is that people use the interpret reduction of movement. So the idea is that you make someone more stable by taking movement away. So lots of exercise programs are then designed around asking people to stop moving. But when you really think about it in biomechanical terms, and you really think about it from a physiological perspective, core stability or stability is really about optimal control, and that's finding the balance between movement and stiffness. So if you think about a runner, and running is something I've recently discovered a love for, and if you think about running, the last thing you'd want is for someone to not move their spine or pelvis. So if you want someone to have optimal stability or optimal control of their spine and pelvis when they're running, you need to have some movement. You need to have movement to do some shock absorption. You need to have movement to be able to transfer load through the body. You need to be able to have movement to optimize the energy expenditure. So core stability is really about optimal control, finding the right balance between movement and stiffness. If you think about some tasks, so some things like lifting up 100 kilos off the floor, you need to be a bit more stiff, so you need to have a bit more reduction of movement. A task like running or walking, you need to shift towards the movement end of the spectrum. You need to have a bit more movement. So every function is slightly different in how much movement and stiffness you need, but core stability and optimal control is really about finding the balance between those two. And there's lots of examples when we look at patients clinically where people can have too much stiffness or they can have too much movement. So if you're giving someone an exercise program to improve their core stability, it's about getting them from whichever end of that spectrum they're at, of too much movement or too little movement, and get the balance right. So it really isn't as simple as just make someone stiffer. And that's unfortunately the misconception that most people have. And I think that's a really key aspect of why there's been so much confusion in the field.
And Paul, is there one muscle that's particularly helpful in giving you the appropriate stabilisation or the appropriate movement?
And that's a great question. And a lot of the work that we've done has been focused on a couple of muscles, and the misconception that comes from that is that the idea that maybe we believe they're more important than others, and people often talk about muscles as stability muscles. And I think, to me, the most important thing to gain from what we understand about how the spine is controlled is that all muscles are important and necessary to meet functional demands. So you can't just have one muscle. You can't just rely on one muscle to provide control. And they're all important. In every function, you'll have a whole orchestra of muscles involved, and different muscles clearly do different things because they've got different mechanical advantages, different anatomical attachments, different relationships to other functions. For example, some of the muscles of your trunk help you breathe as well as help control you. And there isn't one muscle that magically makes you stable. There's muscles that are very good at producing and controlling torques. There's muscles that are very good at controlling what's happening at the segmental level, and all of those things need to be happily married together to have optimal control. So to get this balance between movement and stiffness, you need this orchestra to work. So there's deep muscles that we often get credited to having spent a lot of time researching, like the transversus and the multifidi. They are important, but as part of a team. And I think all of our research that we've ever done has made recordings from multiple different muscles and is highlighting the necessity for integrated activation of the whole team. One of the reasons that there's often been some focus on the deeper muscles is that when you look at people with pain, there's often structural and behavioural changes with those deeper muscles. But it's not exclusively those deep muscles, and that's one of the skills of clinical practice, to be able to identify the particular way in which the muscle system is not optimal for a particular functional context or a particular situation. So it really is a complex interplay of muscles, and the skill of the clinician is necessary to identify which muscles might be important for that person. So it isn't a simple solution of exercise a single muscle and everyone will get better. There's far more to it than that.
And we could love to drill down on the sort of exercises that clinicians could use to set it up, but we won't do that today because we want to make this short and sweet, and we know you've got to get to the Museum of Islamic Art in Doha. But maybe a last one to finish, Paul. Patients can sometimes think that one of their friends got better one way, you know, there's a recipe, one size fits all. How do you advise folks who think along those lines?
I think one of the single most important things that's being talked about in the literature and is being shown in clinical trials is that if you treat everyone in the same way, you might get some effect, but your chances of having a better effect, you've got much better chance of having a bigger, more important effect if treatment's individualised. So most of the literature at the moment does big clinical trials where everyone's treated in the same way. But the data from a whole series of experiments is showing that if you identify the people who are the best responders and if you individualise treatment to the individual needs of the patient, you can have a better outcome. And there's lots of work that's showing that that this is potentially important. We're a long way from having the definitive answer yet, though. We don't have the simple equation where you find that the person has X, Y, and Z, so you apply exactly one intervention. There's a lot more work to be done to get that right. But individualising treatment is clearly going to give has potential to have an impact that's much greater and much more clinically important for the individual patient. For example, one of our recent trials has shown that people who have pain that appears to be more nociceptive in origin, and what I mean by that is that people who've got pain that is consistent with the some of the input being driven by mechanical forces in the body. So people moving inappropriately and having a really predictable relationship to their pain provocation. Those people tend to do much better with interventions where you can identify the features of their movement that are problematic and change it. So I think there are types of pain, but also types of presentation in terms of particular movement strategies, muscle activation strategies, postural alignment strategies, that can help guide a clinician in identifying the best treatment for the patient. So there's never going to be a simple solution where everyone gets the same exercise and is magically better. It may have some effect, but we can probably do much better.
Thanks, Paul. And clearly you're underscoring the need for the clinical expertise, the clinical assessment, and the value of great clinical physiotherapy. And
well, the value of clinical reasoning, of making judgments based on seeing patterns and targeting the individual.
Absolutely, and so integrating the research with the clinical reasoning, so it's an overlap of the circles of evidence-based medicine, really, as we know well. So thanks a lot for your time today and for being on the BJSM Google Hangout. Enjoy your time in Doha and good luck at the conference.
Thank you very much.